So, yeah, thank you. Uh, Coming to I will just briefly touch upon the turning points in the drug regulation. So, this is the Justice Lentin Commission report because it was this commission was constituted because of the JJ Hospital tragedy of diethylene glycol. This is diethylene glycol, as we know, it has become very popular not only in the pharma industry regulators but even in the general public media because of not only of this incident but the recent incidents also. Uh, because of this JJ Lentin Commission report, JJ Hospital matter. Now, what was the regulatory impact? So, regulatory impact was that I will touch upon the coming slides. But what we have learned from this report, so various regulatory actions have been taken. Whether these regulatory actions, the amendment in the rules, our practices are adequate, no. If they are adequate, that incidents that were reported uh, during the Denton Commission in 1986, so those incidents should not be repeated even today. So 1986 is almost 14 years back, but we see that these incidents are reported even today. So we need to do something that once some issue comes to our notice, we should see that issue is solved forever. It is not like that we take a, we take some measures, which is a eyewash, and that is only for the because there is a public outcry, media focus, and then move onward without solving the problem. So recently, Gorakhpur, and then in 2019-20, the Ramnagar, 22-23, Gambia and Uzbekistan, because even last week the Uzbekistan drug controller they talked to us. They said, "What is the action that you have taken?" We have taken action. We have taken action that we have constituted 5 cases on the company. We have cancelled. I mean, the state has cancelled the licenses. That, but we know how long these cases run in the court. And Uzbekistan, they have convicted the importer. They have already been sentenced to about 20 years imprisonment there. And now we say this is under process. And when these licenses was cancelled of this company, only couple of weeks back, he has appealed in the High Court of UP, Allahabad, and that High Court has said, no, the process by which these licenses were cancelled is not in consistence with the general law, and the licenses were restored. So now this message, if I mean, I wanted to tell the message to them when they were asking, but I mean, it's very difficult for me because I am dealing with international affairs. So it is very difficult for me to say that administrative action is all we are not able to take. Uh, so, I mean, how to address these issues that we should reflect. So what happened in coming to the devices part? So as we know, the devices were not regulated earlier. Only the notified devices were regulated. So in 2005, so then earlier IV said disposable syringes and needles they were regulated. Only 3 categories. Then came HIV testing kits and other critical testing kits. Then 2005, these high risk sterile medical devices were regulated. So this is one turning point, of course, in the regulation of medical device in the country. So earlier, no, I mean, except this, hardly there were 18 medical devices that were regulated. Now, the medical devices have come under the definition of medical device. That means all medical device, whether it is a wheelchair, thermometer, or whether it is a examination gloves, or whether it is a PET scan, CT scan. So all of them have come under regulation, and this is going to be a sector in the next 10 years. It is expected to be at par or even surpass the pharma sector. So this is the areas that the new inspectors who come, so they have to learn. There are so many things because this is a hybrid sector. There is engineering, there is science, there is a plastics, there is a polymer technology. there are so many other subjects that need to be learned. So coming to another area, which is a turning point, is the 1996 judgment regarding the common cause versus Union of India. So at that point of time, the blood, when it was taken by donation from a donor and given to the recipient, so testing was not mandatory. HIV testing, HBS, and HCV testing, because of which the percentage of HIV transmission through blood was going up to 5%. So this was supposed to be the most critical, I mean, most the pathway for transmission of HIV, and then came the regulation of the human blood, whole human blood, and its components. So again, uh, this is a point where uh, this is regarding the LVP, where these LVPs were contaminated with fungus, and then they cause death in the patients. That has led to the regulation of the LVPs, that is the CLAA procedure. This CLAA procedure was not there earlier, they were under the state licensing system. Now, because the courts thought the what you say, the regulatory scheme is not working well, there should be a oversight. So that is why the dual system of the state and central government has come in place. So I don't know whether it is good or not, but is it the right thing that we should do, or whether any one can do, whether state can do, if at all, then what should be the modalities and scheme of regulation? So again comes to the Mashelkar committee. This Mashelkar committee is one of the comprehensive studies by any committee regarding the drug regulation. So Dr. Arya Mashelkar, the chairman of the CSIR, he gave very comprehensive report, and these recommendations are valid even today. So I urge all the young officers who have joined recently to please go through the report of the Dr. Mashelkar, so that it is not that, see, because being in the as a drug inspector, as a ADC, or any office, any post, so we do our work, but we should have an idea, so how the system is functioning, and what is the spirit of the system, and then how should we work within the spirit. So often, many times, what we see is that we have spirit, we have the letter of law. So we follow the letter of law, but we miss the spirit. So it should be spirit first, letter of law later. But in case a situation where someone faces difficulty to work in spirit, in such case, so that should be addressed by us, every one of us, so that it should be both spirit and letter of law. Both should go hand in hand together. So, Mashalkar committee was triggered due to proliferation of counterfeit. I mean, by mistake I've used this. It should be the spurious and substandard drugs. And uh, these are the key recommendations. So, creation of the Central Drug Authority, that is one. Amendments in the Drugs Act, and stronger penalties. So, stronger penalties we made in 2008, that the imprisonment has been increased to life. But we don't see in cases where deaths have been reported due to adulterated spurious drugs, even in such cases, we have not seen someone sentenced to life. So, increase in punishment does not necessarily mean that the offender will get the maximum punishment, because of the procedures that are laid down under the law, and because of the lack of understanding of the procedures and following the procedures. So again, these are the three recommendations: the updating, uniformity. So this is the major issue that we face today. So I will come in the coming slides. What are the issues regarding uniformity of implementation? Because Act is same, the rules are same, but implementation varies from state to state. But in India, we are all Indians. We buy medicines manufactured in one state, we live in another state, and what do we expect? We expect uniformity. So medicines which are manufactured in any state would have the same quality, and if that is not the case, then we are. I mean, there's something seriously wrong with our. I mean, going back to then use of technology. So they suggested use of technology. Even today, we are trying to use more technology in application processing, but still, so it only the other day, last week, yeah, I mean this week only, we had I was conducting a video conference on the implementation of WHO GMP digitalization. But our friends are there from the industry, our chief guest, and then so even today I was just referring my phone. I got emails that this should be postponed because of whatever reasons they have. That is a different thing. So my point is, in 2000, Dr. Michelle said use more technology. In 2025, we are telling no, we will postpone it further. Okay. But still, we have progressed a lot. So we have built the four portals with CDSCO. So I think one of my achievements coming to CDSCO is that to build a digital infrastructure of uh, the Sugam portal, medical device portal, the ONDLS portal, and the LIMS, the Sugam labs. That means integrating all the laboratories under the CDSCO for monitoring the testing of samples and issuing of reports. So not only in our country, so we are, I mean, our Indian pharmaceutical industry is disgraced by some cases. One is the Ranbaxy case that everyone knows. If you don't know, please go through that. So there is a crusade, there is a person. So if you go through the social media, there's a person who continuously keeps on pointing out this thing and then say the regulatory system has not changed. So, so I mean, we have to answer him. Not only him, he is a representative of so many people. So we have to answer him with a voice which is unequivocal, without any confusion. But are we in a position to do so? So this is another case wherein in 2013-14, so US FDA, if you have seen, so there is a lot of what to say import alerts. So many drugs which have been manufactured by all the pharma majors in the country, all of them have been under prohibition, import prohibition into USA because of main issues data integrity, data fraudulence. Are we in a situation to identify this data integrity as an inspector? And if we have to identify what skills that we could have, so because if you see, except the MSMEs, all major pharma companies now are using IT systems. So are we properly trained, educated to inspect this IT system, to assess them, and do the validations, software validations? So this becomes very key in future. Even today, it is key. In future, it is going to become more important. So, coming to this, recently, Dr. Narayana said we went to other countries, we went to the USP. So, USP, it they have given, so in it, 183 companies in India have more than 10 APIs which are under DMF. That means you can see the importance of Indian pharma industry in supplying not only the formulation but also the APIs to the entire world, including the USA. When this is, I have to say that there are some shortcomings which we have to correct. There are some achievements. So we have to recognize both. Otherwise, we will be discouraged. So coming to the affordable treatments, what the Indian industry has done. So Indian industry has developed this ART, antiretroviral therapy. The CIPLA has been in the forefront. So it has developed quality anti-ARTs at 1 per day. And because of that, more than million HIV lives were saved in Africa. This is something, a big achievement for CIPLA, Indian Pharma, as well as as the country as a whole, as well as the regulators. Vaccines. So we see that many countries are very poor countries. So their budgets are very small. They are not in a situation to buy expensive medicines or vaccines from multinational companies. And that too, uh, the immunization vaccine immunization program, which are crucial because all these diseases they reduce the infant mortality and they have increased the lifespan of the children because the first 2 to 5 years is very key in the developing countries, underdeveloped LMIC countries, where infant mortality is very high because low cost quality vaccine we have been supplying to the WHO more than 60%, and these have been affordable to those countries as well as WHO budget. Because of that, the lives of so many children have been saved. So this is an achievement too under pre-qualification. Similarly, in relation to the vaccine, these are medicines. So P2 medicines, pre-qualified companies products are the largest in the entire world in India, which supply to UN agencies like UNICEF, WHO, and many other UNIAID, many other where they supply the life-saving drugs at a very affordable cost. So we supply more than 60% to UNICEF, 90% anti-malarial to Global Fund, and 30% WHO DQ finished products come from India. So coming to our a screenshot, a moonshot of bird's eye view of the total pharma industry. So more than 40% generics are supplied to US are manufactured in India, UK, 25 to 33%. So like that, we have been seeing from time to time. No. So we have seen some turning points in the drug regulation. We have seen what are the achievements that Indian pharma industry and because their achievements is our achievement. And then what are the current challenges that we have? Coming to the challenges. So what we have seen the past, we are in the present. The present challenges is the shared responsibility. In the earlier slide, I said the shared responsibility is that is implementation of the drug regulation uniformly across the country. So this is the major key problem that we face today. How to implement the laws uniformly across the country. So within the family, there is a divergence. Their parents, the children, each think in their own way. Parents by experience, children by by youth, by hormones, or by whatever they diverge. So the society, then there are more complications. There are external forces also. So like each department, there are individuals, there are officers, there is a government. So they also drive in different directions. And when it comes to the country, then it is more fragmented. Then how should we achieve uniformity across the country? So this is a key challenge. So I'm here putting only the challenges. We will come to the answers later, if at all these are answers. I my point is that everyone should find out their own answers at the individual level, at the state level, at the country level. It is not possible that you have one answer for everyone. It may be a hybrid of many, many strategies. The capacity constraints. So, the number of drug inspectors, so the number of manufacturing units, number of sales units, are they adequate? So, are did we do any study that how many officers are required for inspection of how many units? Earlier, our rules, duties, and responsibilities of drug inspector says one inspection per year, but later, so it has becoming more confusing sort of thing. In one place, we say once in a year, one place we say once in 3 years, in one place we say by risk-based approach. So which what we should follow? So if a competent authority, a controlling authority gives a memo to a drugs inspector, why you have not inspected this particular license once in a year? So whether he has an answer, whether the competent authority, the state authority, whether they have given any directions, because there are at three different places, there are three different suggestions or rules. So which the drugs inspector should follow, whether we have an SOP. So these are the things that we need to do at work. So divergence from the global practices. So if in 1970, if we have our own system of regulation, we can understand. In 2025, whether we have our system of regulation which is different from the global practice, is it right or we are lagging behind? Because of the reason, if we are an isolated country, then whatever we do, world is not bothered. But we are not an isolated country. We are country integrated with 200 other countries. Because of the reason that we are supplying to 200. So, an inspector, whether in Arunachal Pradesh or Jammu and Kashmir or Bhakti or Gujarat or Maharashtra, he is not only an inspector for that state or region, he is an inspector for the globe because the drugs there manufactured there are being exported to all these countries. And the regulators of those countries they come to us with their request for verification of documents, whether COPPs or whether GMP certificates. They are relying upon our documents. They are relying upon our inspection. So if we are not in a position to satisfy that we whatever the systems that we have, the practice that we do is in line with their requirements, then it is it is very right to say that why we should buy from India. Okay. So that we should understand. We should understand and we should try how to address this how to address this issue of divergence from global practices. So what are the global practices and how we divert from that? So that's a big subject itself. We will see whenever the topic comes here. And lag in harmonization. So I mean these two are little bit coming together. Global practices and harmonization, whether we harmonize with them, at least in spirit, as I said earlier, the spirit, if not the letter of law. The spirit is whether we give them a safe and quality medicine. So if we are not in a position to say so, then we are not even, we should not even think about letter of law. So, I mean, these are the current challenges. And regarding these current challenges, I mean, it's already 2 o'clock, so I would like to speak many slides. So concurrent list, we know uh, because every one of you is in some way a student of law. So the central government there is a list of the three lists are there. That is under the concurrent list, entry number 19. It says the state and the center both have the power to make rules. But here, so what happens? Our act is a central act, so that is why it has supposed to be uniform across the country. But what happens if the state would like to make their own rules? Of course, they can make their own rules. rules are in contradictory to the central rules, then that rule would not stand. So the central rules will prevail. But in cases where the state would like to make rules, what they do, they send to the central government. We receive almost every 2 to 3 months, we receive some sort of draft rules from various states. And in these draft rules, they say it is a punishment. Give powers to the police officer to launch prosecution. So, like that, there are many suggestions that we have, but keeping in view of the drug rules and other rules, we view our recommendation. If the president gives their assent, then those rules become implemented in those states. Otherwise, the central rules prevail. So, because there is always a thought like a state whether CDSO है ये state है why CDSO को क्यों मानना है CDSO rules बनाता है and CDSO is trying to take power from the state. It is because of the issue of uniformity, because of issue of lagging harmonization. If we are thinking about harmonization with the world, what about harmonization within the country? Are we in a situation to harmonize between the practices within the country? So how we should do that? Who should take the lead? And the CPSCO, if a drug is manufactured in one state and it is supplied to all other states in the country, what the CPSCO does is to represent all other states in the country to see the drug manufactured is as per the compliance with the rules or not. So if that work is not there, then each state will become an independent country, which is not answerable to anyone. So once the state has taken the responsibility to address this issue of sharing of powers between the state and the country. So again, coming to the global integration, so there's something called a global benchmarking tool. The global benchmarking tool, which the WHO comes and assesses us. So why WHO? We should allow WHO to assess us because we are exporting to 200 countries, and those countries are not in a situation. Many countries, some will come. Many countries are not in a situation to come and inspect our facilities. So what they do, they take our GMP certificates, COPP certificates. They accept these certificates as valid. But whether we are following the global practices and issuing these certificates or not. So that is verified by WHO. Okay, I get the signal. 10 minutes. So there are 9 Indian